Hello, and welcome to Health is the Key, the podcast that explores the health and wellness issues that matter to 1199 SCIU healthcare workers. I'm your host, Elizabeth Moore. Time was when most people thought menopause was the punchline to a joke, rather than the natural, if somewhat complicated life experience it is. But lately, menopause is being taken more seriously, and women are getting some answers, to questions that they were either embarrassed to ask or that were ignored. So today, we're pleased to welcome Dr. Samantha Dunham, a clinical associate professor in the Department of Obstetrics and Gynecology at NYU Grossman School of Medicine and the co-director of the Center for Midlife Health and Menopause at NYU Langone. Dr. Dunham will help us separate fact from fiction and explain how women can find the care they need for this latest step on their health journey. Welcome to Health is the Key, Dr. Dunham.
Hi, thank you for having me. Pleased to be here.
So most of us know or have a general idea of what menopause is, but can you explain exactly what it is medically speaking?
Sure. Menopause technically is for people who are having regular periods when women stop having periods for a year. It's when ovulation stops and there's no period for a year. And that signifies menopause.
So it is that specific, 12 months, you're in menopause.
Yes. But
Okay.
The really interesting time is the perimenopause. The perimenopause is significant because it can be a long time, and it really is as people get older, the ovaries stop working as regularly, and the production of estrogen really changes over time. And that's perimenopause. And that's signified by symptoms. It's signified by changes in hormone and signified by changes in the menstrual cycle.
And so the difference is just that perimenopause is more of a slowdown and menopause is a stoppage.
Is the cessation, exactly,
Okay.
yeah.
Okay. And are the symptoms similar for both?
Symptoms are very similar. So some symptoms that we think about are things like hot flashes and night sweats, vasomotor symptoms. Joint aches are incredibly common during menopause, sometimes palpitations, often mood change. So we see things like anxiety and depression, irritability. Sometimes there's something called brain fog or a little like almost mild cognitive impairment that can happen. And then the last area that's affected is the genitourinary system, or it's called genitourinary syndrome of menopause. And it's when that lack of estrogen really affects the tissues of the urogenital system.
What age do most women experience perimenopause and then menopause?
Yeah, so the average age in our country is about 51 and a half, between 51 and 52. But really any time, 90% of women go through menopause, which means they reach menopause between 45 and 55. But any time after 40 is considered pretty normal. And late really is like after 58.
And what are some of the differences between women who start early and who start later? Are there any, or is it just happenstance?
Yeah, there's big differences. So for people who have like a premature menopause, which is before 40, they have increased risk of kind of problems related to cardiovascular health, bone health, and also brain health. So for those women who have really like premature menopause, so less than 40, we really suggest that they start hormones. And then there's sort of a continuum between 40 and 45, which is considered early menopause, where they have a little bit of an increased risk as well. And then between 45 and 55, it's sort of considered normal. It depends on their symptoms, what they would want to do.
We talk so much about symptoms like hot flashes and hair loss and sleep disturbances. And I think maybe that's what kind of gave menopause a bad rap, why it wasn't taken as seriously. But there are more serious consequences, such as what you were talking about, heart health and osteoporosis and things like that. So what happens exactly during a hot flash, for example? And I think most people put hot flashes in the category of, they're just annoying, but they're not serious.
Yeah. They can be annoying and they can be serious at the same time. I mean, we call them bothersome, but I don't know if that captures the impact. So, we kind of classify them as like mild, moderate, and severe. And mild is just when people feel a little warmth, but it doesn't interrupt them. And on the other end of the spectrum is severe, where people feel like an intense heat.
Break out in a sweat.
Yeah, they break out in a sweat, and they really have to do something else. Like they can't continue to do what they're doing. They have to cool themselves down. They have to open their collar, really try to make themselves comfortable. So that when you're no longer able to do what you were doing, whether it be reading or speaking or sleeping or whatever you're doing, that's severe. Right. And that interrupts your day.
Your whole life. Yeah.
Your whole life, exactly.
Do some women not experience any symptoms, or they're very mild that they don't notice them?
Yeah, there are people who don't have symptoms. There are people who kind of sail through menopause and just notice that their periods have stopped. And, they're not what I see commonly because I see people for symptoms. But I also practice regular gynecology, and I have lots of patients who don't complain about symptoms.
Can you talk a little bit more about the serious symptoms that women experience? How can people prepare for it, even prior to perimenopause?
I think just education, right? So being aware that this might be on the horizon. And symptoms can happen, even just as maybe the period's just about to change. And looking at things like sleep disruption, looking at mood, with maybe a little more irritability, a shorter temper, episodes of rage, certainly, those are things really out of the ordinary things. I think being aware is probably the first step. So you can seek help, or talk to your healthcare practitioner about what's going on to look for resources.
Are there lifestyle changes you can make that would help
Always.
stave off? Always.
Yeah, in general, right? It's it's really a transition point in life. Going into it, feeling, having support systems in your life, obviously social support, being healthy in terms of the big things like eating healthfully, thinking about exercise and weight-bearing exercise becomes more important because of the loss of lean body mass that happens really from the times in the 30s, that's happening over decades, and then establishing good sleep patterns. There's things you can do to prepare.
And are there some predictors? I've heard that if your mother had an early menopause, you'll have an early menopause. Is that more
there is
myth?
There is some genetic component for sure. And for women whose mothers had very early menopause, like less than 40, it's important for them to bring that up with their physician.
So as far as lifestyle changes, so not drinking as much, just the basic lifestyle, healthy lifestyle habits to nurture. But I know that when I had experienced my first hot flash and then had a series of them, and I went to the doctor, and it wasn't taken very seriously. In fact, one doctor told me to stand in front of the freezer.
Well, that's really not very useful.
No. So even
I'm sorry that happened.
Thank you. So even though people are saying that menopause is having its day, and celebrities are coming out writing books about it, Oprah's talking about it, there still aren't a lot of answers. So what are some of the advances that have been made that are helping women navigate this very particular time of life?
I think the kind of elevation in conversation from celebrities talking about it and just people on social media talking about it is helpful because it normalizes the experience. And then I think that the healthcare providers who are being approached by this patient population have that sense of, really wanting to help too. And I think there's been a reexamination of the original study that scared so many people.
Yes, I did want to get into that.
Yeah, so I think that's changed so that there's a better understanding about the use of hormones, which can help certainly in the late perimenopause and the menopause. And there's also, a number of non-hormonal options. There's lifestyle things that people can do and other complementary therapies that help with symptoms. There's really a huge menu of things that we offer people who are having symptoms. And I think that's becoming just more accessible as more people are talking about menopause and saying this is an issue in my life and just not accepting that they have to suffer.
Which I think a lot of women did in the past. And it's great to hear that there is a menu of options now. So can we talk about HRT? Is that the first line of defense?
Oh, yeah. So, we use menopause hormone therapy, like MHT now, because it's not really a replacement as much as it is treatment for the symptoms. And so for women who are having symptoms, we offer them estrogen. And if they have a uterus, we offer them a progestogen to protect the uterine lining. And what that does is really, affect the brain and affect a lot of the tissues in the body to help with the symptoms. It helps with hot flashes. It can help with sleep. It can help with mood. There's some very direct benefits and there are some indirect benefits. And for most women who are generally healthy, it's very low risk. And it depends in large part on their prior history and kind of a discussion with their healthcare practitioner to determine if they're good candidates or not good candidates. So yeah, it's really individualized care, and it's the gold standard for treatment for vasomotor symptoms, for prevention of bone loss, for genital urinary syndrome and menopause. We use it all the time for those indications, and then sometimes for some other reasons that have some indirect benefit as well.
And how is the estrogen administered? Is it pill form or?
Yeah, so there's lots of ways. It comes as an oral option, as a tablet, and it comes as non-oral also, so either as a patch or a gel, and there's also a vaginal ring for the estrogen.
You had mentioned progestogen. Is that always recommended when you start someone on hormone replacement therapy?
If they have a uterus, for sure.
Okay, because that helps
to protect. Yeah. Okay. Otherwise, if somebody's is taking estrogen and they don't take a progestogen, it just makes the lining of the uterus grow, and it can become a problem for endometrial lining.
And I think a lot of women still have that idea of that study that scared everyone in mind. Can you explain that a little bit and then tell us the flip side of the result?
Sure. It was a huge study. It was called the WHI study, and it started in the 90s. And it was a study that was designed to look at cardiovascular risk and bone health and some other aspects of women's health. And the study used an estrogen, which was called Premarin, which is called a conjugated equine estrogen. And they also used another medication called Prempro, which is the Premarin plus a progestogen. And they had a placebo arm as well. And so it was a huge population. I don't remember exactly how many, tens of thousands of people, of women. And it ended up being halted earlier because they saw increases in cardiovascular risk, and then they saw increases also in breast cancer risk. After years of assessment, looking back at it and understanding that the population average age was 62, that really skewed those results. So these were people who, many of them had underlying risks for heart disease and stroke, et cetera. And so, with reassessment, they saw that it led to this idea of something called the timing hypothesis, where there's sort of a window of initiation of therapy that's safer, which is when it's closer to the time of menopause or before the age of 60. So the reassessment of that data changed our understanding. And the other thing is we use different kinds of estrogens. Like this was an oral estrogen, and we use transdermal estrogen often, and that carries a different risk with it as well.
Is there a preference?
It really depends on the patient's choice to some degree, and also, in talking about the options between them, oral estrogen has a little bit of a higher risk of something called DVT, which is a clotting disorder. But, the risk is very slightly increased. It's not hugely increased. It depends on the patient's preference.
And what if a patient doesn't want to go on HRT? What are the options for that?
There's lots of non-hormonal medications. There's also cognitive behavioral therapy, which is data-driven to help with vasomotor symptoms. There's also a medication called paroxetine, which is known as Paxil, at a low dose, and that also has FDA approval to reduce hot flashes. We use things like SSRIs and SNRIs. We use gabapentin. We use something called oxybutynin, which is something that's a medication for urinary incontinence, for urge incontinence, and that has benefit too. There are many options.
Right. So there's not just do this will be the best way for you. You have to look at each patient as they come.
And really people come with their own kind of expectation or concern, and sometimes just seeking guidance about what's available. And they want to mull it over and do their own, exploration and then make a decision.
Is there often a trial and error
100%.
step to the therapy? Yes. to see whether something takes.
Yeah, and especially for hormones, it takes about 3 months to really see the full effect I mean, people feel often a difference within 2 weeks or 4 weeks, but then it's 10 weeks or so before they really feel the full effect of the therapy.
I wanted to ask you about how long to stay on hormone replacement. Is there an end date, or is it just a case-by-case basis?
Yeah, it's more, initiation. The timing of initiation is really important in terms of like when people start hormones, but there's no like absolute time they have to stop. And, we've learned from studies over the last 15 years that symptoms can last for a long time. Everyone used to say it was 1 year and it's over, but it's not 1 year. It's more like 4 years or 7 years, and in some populations up to 10 years. People stay on them for as long as they need to be on them. Some people take hormones for bone health too, so in that situation they may decide to stay on them even longer than symptoms for that bone health. That's a very individual case-by-case decision.
So asking for a friend,
Yes.
can symptoms last longer than 10 years?
Yeah. Oh, absolutely. I mean, probably 15% of women are having symptoms until their 70s.
Wow.
Yeah, it continues. And they're not as severe, but they're still having symptoms.
I feel like we've really been giving menopause a bad rap, all the symptoms and terrible things.
Yeah.
Are there any positives that women can look
absolutely.
forward to?
And everyone doesn't get everything. It's kind of a grab bag. You might get nothing. And I think at the end of the day, there's certainly like a different kind of wisdom that emerges. There's a lot less distraction from your irregular periods. So there's a lot of benefits from that perspective.
So it's not all bad.
No, yeah. And there's not that up and down like hormonal, for people who have PMS or really feel their hormonal changes. I mean, they can go into smooth sailing after menopause.
I had read that people who experience a rough PMS will tend to have a tougher time with menopause. Is that true?
There is data. So for mood changes, so people who have like either PMS or PMDD, or they've had postpartum depression, or maybe they even had a rough puberty with mood change. So at the time of their perimenopause, they're at higher risk. It's almost like they have these hormonally like vulnerable brains, higher risk for mood issues, so depression, anxiety. And most of those people know who they are, and they'll come to us and say, I'm concerned about this, and we'll be in close touch with them and support them hormonally through this time.
And for people who don't experience symptoms, sail through okay, are they at risk for other conditions when they're not getting therapy for menopause?
Yep.
Like, is that something that they should ask their doctor about?
Yeah. We know that at menopause that cardiovascular risk accelerates. So we really see a dysregulation in lipids. So LDLs often increase, triglycerol increases. So that's something that people should be plugged into. Prediabetes happens to about 25 to 30% of women at this time. We know bone loss happens, and bone loss starts about 3 years before menopause. So just at the time when the menses are really skipping. So it's like a 60-day or greater interval with no period. And that's a big heads up when we start thinking about, really weight-bearing exercise is important here. Calcium intake remains really important, vitamin D, protein intake. And that change in the bone happens for about 5 years. And then it mellows out. Like it's not as big of a bone loss of the mineralization of the bone after that 5-year time. All those things are still happening. They're just not. It's not as evident.
And we wanted to ask: is there a difference between when it's menopause related or age related, and does it make a difference?
I guess things that are kind of menopause related, they probably seem more sudden in terms of symptomatology. Like they crop up and seem more sudden. I think age-related changes are probably more gradual. Sometimes we don't know.
Well, speaking of gradual changes, we know that men experience not full-blown menopause, but they experience changes too, and yet women are the focus of menopause jokes and everything in the culture. So can you explain a little bit what men go through and how it differs from what women go through?
I'm really a gynecologist. But we know that, women's, like the ovarian function, like loss of, decreased estrogen is pretty marked. And it ends up looking like a decline over time, but like with jagged ups and downs. So it's declining over time. And I think that for levels of testosterone, it's much more gradual over time. So men, too, are undergoing changes related to testosterone levels, but the levels aren't, it's not this acute drop-off that women have during a certain number of years. It's just more attenuated.
So it's more sudden. And are they at increased risk for age-related heart disease and weight gain and all that?
Women's cardiovascular risk does increase to meet a man's at 20 years. With that loss of estrogen, that certainly happens. And then in terms of does men's heart risk increase over time with age? Yes. But I don't know if that's related to testosterone levels or not.
Right. And in your practice, what is the most common reason that they come to you?
A lot of people come with weight gain because the weight gain is often sudden and it comes with a change in shape. So it's not like the weight gain they've had. And people say, I'm doing nothing differently. I'm eating the same foods. I'm exercising more. I'm being more careful. And still people are gaining weight and it's in their bellies. The pants don't fit the same. And it's just really upsetting. And I validate that because the belly that develops links to visceral fat and links to increased risk for cardiovascular disease over time. So it's an important thing to address. So that's one complaint that is pretty common. And then, joint aches are really common. I think that's more common than people realize. And sleep disruption. We see a lot of sleep disruption.
You've answered many of our questions, and I'm sure our members will have more. But if there's any last thing you'd like to leave with our members to think about menopause, or you're approaching it or in it, any advice you can offer?
Yeah, I would say seek help if you're having a rough time and know that there are lots of people going through this as well. And if you don't get the answers that you need with your physician the first time you meet with them, see if you can meet with them again for just a problem-based visit.
Thank you. And we thank you for coming in and talking about this topic that affects everyone.
Oh, yeah, my pleasure. I'm happy to talk about it.
Tune in later this month to our October keynote to hear Dr. Dunham discuss how more and more women are advocating for themselves, finding answers to their questions, and getting relief from symptoms. She also shares simple lifestyle changes women can make to support their overall health. Speaking of overall health, it's Breast Cancer Awareness Month, so if you're a woman aged 40 or older, be sure to schedule a mammogram as soon as possible. Under 40 but not sure of your risk? Talk to your doctor about the screening schedule that's right for you. For more information on what you heard today, please check our show notes. And remember, subscribe to Health is the Key wherever you get your podcasts. This podcast and its content are presented solely for general informational and entertainment purposes. The information and opinions provided on this podcast are not intended as legal or medical advice and do not constitute or serve as a substitute for professional medical or psychological treatment, diagnosis, therapy, or other types of professional intervention.